Again, welcome to today's session, Winning Price Transparency Strategies for 2021. This is the first of a three-part webinar series on preparing for revenue cycle success in 2021. And this really is most likely the most time-sensitive subject since the new price transparency mandate will be in effect in just over 60 days. So just a couple of housekeeping items before we get started. We do have 30 minutes scheduled for today, but we'll stay on the call late for any questions you might have at the end. And if you do think of any questions, go ahead and enter them in the chat window in your control panel. And then the second point is that this will be an interactive session. We are going to have a couple poll questions running, and we're also going to be using the live chat as well. So be on the lookout for your message alert in your control panel. It's a red bubble that'll pop up if you do see a chat come through. So just some brief introductions. I'm Brad Josephson. I'm the Director of Marketing here at PMMC. PMMC is a revenue cycle management company. We're based in Charlotte, North Carolina, and we have about 450 clients, hospital clients across the country. And I know we met some of you recently at the NARI virtual Revenue Integrity Symposium, so it is good to see some of you back with us today. And I would like to introduce our speaker for today, Greg Kay. Greg is the Senior Vice President of Revenue Strategy here at PMMC. Greg's a veteran in the healthcare space. He's been in healthcare for 30 years. And lately, he's been very busy helping our hospital clients prepare for this new mandate. So with that, I'm going to turn it over to Greg.
Great. Thanks, Brad. Good to be with everyone today. And as Brad said, happy Wednesday. So in today's session, we're going to focus on a few of the upcoming components of the new price transparency mandate. We're going to cover a number of common questions that we've been receiving with our clients. We're going to address several key steps that should be considered leading up to, as well as some post January 1st steps that you should be taking. And then we're going to wrap up today's discussion with a few analytical reports and concepts as we move forward and really work through the need to balance price transparency with maintaining net revenue. In other words, how do we transition from what we historically referred to as strategic pricing to really more rational pricing, if you will. So in terms of the mandate, last August, CMS issued draft rules for comment, and our industry responded with a significant amount of input this time last year. And the main objection that was really raised at that particular time was to not have to post the negotiated rates. Last year, we really thought we had plenty of time, and CMS upheld really their directive. They've incorporated a number of items. There was a lawsuit that our industry did fight with CMS. Unfortunately, that the rules have been upheld thus far. At this particular point, we still see the final rules being scheduled for January 1st, 2021. So we've got about 60 days to be prepared for the upcoming steps. From a technical standpoint, the final rule is CMS 1717-F2. And I don't know if everyone is aware, just within the last couple of weeks, CMS has published an update to their website with additional support documentation, specifically for price transparency. Here you can find helpful resource tips, an FAQ document, some other resources that are available. If you have not used this particular website, I would recommend you go out and take a look at the material. There is nothing really new that has been published, but I think it may signal certainly CMS's intent to push forward with the rule that's as it's currently written. As I mentioned earlier, our industry did, through several trade associations, file a suit in an attempt to block these rules. The legal action, if you will, was really focused around the rule being an undue burden with the amount of material that was being requested, and the fact that it did undermine competition from the standpoint of publishing the negotiated charge. I think it's safe to assume that at this point, there will continue to be suits. This is probably going to be a few years in the making, but it's certainly not going to stop CMS, probably even with the upcoming election, to continuing to require and move towards our industry being more transparent with prices, if you will. So we do still see January 1st as being the real effective date for this. So that leads us to the next question, and that is, who is impacted by price transparency? Basically, it's any hospital that is licensed by a state. And to clarify, CMS in the final rules did note that it is for all hospitals, not just Medicare licensed facilities, that it includes specialty hospitals, critical access facilities, rural facilities. It also includes all sites of services for acute care facilities, including HOPDs or the hospital outpatient departments. So as a level set in the final rules, CMS did provide some additional detail and specific examples with two baseline requirements. The first relates to hospital charges, and there CMS clarified the definition of what's referred to often as the machine readable file, or some will refer to it as the standard charge file. And within the standard charge file, there are 5 components for that piece. There is the gross charge for all items and services reflected on the hospital CDM, and those defined in payer contracts, which leads to the payer-specific negotiated charge, which I mentioned is one of the more controversial items. The discount cash price, which our industry had noted in the comment period, that's really what consumers would want to know. So this is the cash price that a patient would pay at time of service. The de-identified min and max charge, which is the lowest and the highest negotiated rate for each item and service, or the 5 components that make up that standard charge file. The second component in the final rule is a list of shoppable services. And this list of shoppable services, there are 2 different options that hospitals have to post this information. CMS provided a list of 70. Each hospital can come up with an additional 230 to make a total of 300 shoppable services. But that list of 300 shoppable services can be posted through a comprehensive machine-readable file, or it can be deployed through a consumer-friendly patient estimation tool, so a commercial estimation tool. CMS acknowledged in the final rule that many hospitals did have self-service estimate tools, and that's really where the mandate is focused, is helping consumers understand their cost. So the question often comes up as we're working with clients is, if the self-service estimate tool eliminates the need to post the machine-readable standard charge file, it doesn't. You're going to have to post both that standard charge file as well as deploying the shoppable services through either a file or through a self-service estimate tool. So before we review an example machine-readable standard charge file, I do want to touch on a couple of additional definitions as it relates to the negotiated charge, because that's where a lot of the items, a lot of the questions do come up. Brad, if we'll go to the next slide. So one of the things that CMS added in the FAQ was just a more clarification around this baseline definition, if you will, of items and services. Items are those components that make up your CDM. Services are the areas where we have grouped as an industry through your payer contracts, items into service packages, if you will. And these things are typically the services that relate to an inpatient admission or an outpatient department visit, where you either have a standard charge or you have group charges together, things like supplies and procedures, room and board, those facility fees, if you will, that would roll up to a standard defined service package. The service package that CMS defined is really an aggregation of those items and services into a single service definition, if you will, from the payer contract. This is often an area where you would have defined a reimbursement rate or negotiated process. Things like a per diem rate or a case rate would be an item or service package that you would roll up, if you will, in that negotiation process. One of the other questions from a baseline definition would be, what is the base rate for a service package? And Brad, if you'll move forward one slide. The next slide, Brad. There we go. So a base rate is really the payer-specific charge, or the negotiated rate, if you will, that you have in place with a payer for a service package. A base rate is typically not going to be found in your CDM, but it can be found really in the payer contracts. In the final rules, CMS referenced that it can be found in the billing or the accounting system, which really is not how we bill for services. But they did reference it would be what would be referred to quite frequently as the rate sheets that would be found in the in-network payer contracts with your third-party payers. CMS did go on to really clarify the base rates that should be used and listed in that standard charge file for your negotiated charge is not the final payment or reimbursement rate for that entire service package. It's just the base rate, if you will. So it would not include things like carve-outs, your high outliers or low outlier discounts. It's just the base rate, whether it's a per diem rate or a case rate or a per unit rate, if you will, for a particular service. So for January 1st, Brad, we'll go to the next slide. So for January 1st, we're going to be needing to produce a single file that needs to include some data points that CMS outlined in the final rule, kind of working from left to right across the screen. It's going to be listing a easily understood definition that's likely going to be your charge description. You can include your CDM code. That's not necessarily required, but it could be a field that you would want to include. The related CPT HCPCS code is a required item, as well as the NDC code that you would need to list. CMS did clarify that if you have multiple facilities, you're going to need to list each facility. If you have tiered pricing and you have a different charge rate for an inpatient versus outpatient service location, you need to list and clarify that particular rate. CMS did note it would be helpful to list things like the revenue code link, but that's not a required field. So as you see here, we would be listing the gross charge, similar to what you have today on your two-column file that most hospitals have posted. You're going to have that description with the gross charge, and then we're going to be listing also the cash price. And for most hospitals, the self-pay cash price is the discount off of charge, so we would be listing that in the CDM tab, if you will. So this is what the patient will be paying at time of service. CMS did clarify that that's what they would be paying, not necessarily what they would be paying up front, but it's the total obligation to pay. The de-identified min and max is really just the highest and lowest across all payers that are reimbursing under that methodology. And then for all of your payer contracts that are reimbursed as a percent of charge, you're going to be listing those under the percent of charge tab, as we have listed here. And if you have, as an example, 20 payer contracts that have different percent of charge reimbursement. You're going to have 20 different columns with each payer specifically called out by name. Here we've got payer A, payer B, payer C listed in this example. You're going to need to call those out specific to the payer. And then for your payer contracts, as you can see on the lower left-hand side, you're going to have those payer contracts where you have a prospective payment rate negotiated with that organization, where it's something other than percent of charge. You're going to be listing in separate tabs the base rate scheduled for each of those payers. And in this particular example on screen, you can see these are inpatient base rates. You do the same thing at the outpatient level. On the inpatient side, you've got DRGs mapped to a service payment group, to a charge, to the reimbursement methodology, just for clarification purposes. The outpatient is going to be by CPT code or HCPCS code, linked to a description such as APC, ASC reimbursement, other methodologies that you may have per the payer contract rate schedule, the corresponding base rate, and then the reimbursement methodology. CMS didn't specifically call out the reimbursement methodology. We think it's helpful, especially when you have per diem rates versus case rates, or some outpatient reimbursement may be a per unit. Other services may be listed as a per case basis. So it's helpful to provide that clarification, if you will. A common question is, does Medicare and Medicaid need to be listed? The short answer is no, because those are not contracts that are negotiated. Those are contract reimbursement methodologies that are provided to you as a provider. But if you do have Advantage payer contracts, obviously Medicare and Medicaid is the foundation for those, so you would be listing the base reimbursement rates through those Advantage plans. Another common question that has come up is, doesn't displaying the payer-specific negotiated rates publicly violate the confidentiality clause of the hospital contract with third-party payers? CMS did recommend hospitals use the time before the 1/1 date to review their contracts, revise as necessary to ensure that you're compliant with the hospital pricing transparency final rules. And even if a contract between a hospital and a payer contains those provisions, typically contracts also include exception language where you do have to follow federal law. So federal law typically precedes contract law. So you just want to make sure you review your contracts in that regards. As it relates to shoppable services, CMS did provide some significant detail with how that shoppable file needs to be formatted. It needs to include a primary code, a shoppable service description. They did provide some guidelines. As I mentioned earlier, there's a list of 70 services that need to be listed. You've got the flexibility to determine the other services. If you go with the self-service estimation tool, CMS did recognize there is the need to capture certain patient demographic data. So name, insurance group, information. You can collect that information, especially if you're incorporating an eligibility real-time patient benefit check. So really kind of regardless of the option that you go with, the information is going to need to be prominently displayed on your website with the machine readable file. It needs to be easily found and accessed without restrictions. CMS did reference when they said it needs to be available without barriers. They define that as it needs to be free of charge. Users should not be required to enter a username or password. They should not be required to submit information such as PHI data to access the file itself. And they did provide some very specific formatting in terms of the naming convention. So you should go out to CMS's website and make sure you're following that. In terms of whether hospitals will post the shoppable file or deploy a self-service estimate tool, thus far, our experience is about 80% of our clients are deploying a commercial estimation tool. About 20% are going with the posted file. CMS did note, as I mentioned a moment ago, greater flexibility with the internet-based price estimator tool. There are really just a few requirements that they've listed in the final rule. It has to have the 300 shoppable services. It needs to allow a consumer to obtain an estimate with what they're obligated to pay for that shoppable service. The tool needs to be available at all times when the consumer is shopping. It has to be easily and fully accessible, and it can collect PHI information to create the estimate. So that's one of the big differences between the shoppable file and the estimation tool. There is PHI data that, as we know, is required to actually create the estimate to actually go out and check the benefit information. Brad, I think we're going to take a poll question here.
Yeah, thanks, Greg. We'll take a break here and we'll do a quick poll. So the question here is, do you have plans currently to be ready for the CMS price transparency mandate? And we'll go ahead and launch that poll. So the options here are, yes, we're ready now. We plan on being ready by January 1st. We're struggling, but we hope to be ready on time. We have another strategic approach, or not applicable to us. So please go ahead and give your responses there. And we'll give everybody about 30 seconds to get their votes in. All right, looks like most people have voted. Let's go ahead and close that poll out. And I'm going to go ahead and share the results here quickly, Greg. So it looks like about 45%, half the audience, does plan on being ready by 1/1. And almost the other half of the audience says they, about a third, are struggling, but do hope to be ready by January 1st. So relatively good news. It looks like most people are at least well on their way to meeting the mandate. And Greg, I'll turn it over to you to continue on with the presentation.
Great, thanks, Brad. Good question there. So for those that will be ready or in the process of being ready, you know, I think a common question is, well, what happens if we aren't ready? CMS did outline, and the material that you see here is from their updated website recently in the FAQ piece. They did outline some specific enforcement guidelines. The penalties at this point are not substantial from a monetary standpoint. The first piece to note is from a monitoring compliance standpoint, CMS will be evaluating complaints made by individuals or entities. So there will be a reporting process where groups or individuals can file complaints with CMS. They'll be reviewing other analysis of non-compliance. They'll also be conducting an audit of hospitals' websites. So if you have something posted January 1st, you're less likely to be a target than not having anything posted. So that's one thing to keep in mind. The penalties that they've noted may be applied based upon one or more non-compliant items. CMS may issue a fine after providing a warning of the issue and or requesting a plan of action. The financial penalties for this particular item is $300 a day, and the offenders will be publicized on a CMS website, if you will, a wall of shame for those that really have elected to really not do anything at all. It's important to keep in mind that with the enforcement process, there is an appeal process through the traditional administrative law judge, which means you have to have a documented plan, whether your files or your estimation tool is 100% compliant or not on January 1st. You're going to be far better off with a concrete plan, specific steps on how you have been moving forward, and having a documented process of being sure that you are completely compliant. So we do recommend everyone that's moving through the process, be sure you're documenting all of your steps, just like you would be doing with any other process. Documentation is always critical. So moving beyond January 1st, I wanted to touch on a couple of analytical considerations that your team should be starting to incorporate. As we saw in the poll a moment ago, most hospitals will have checked the box, but really we'll need to begin thinking through and begin managing the impact of additional data and the increase in consumerism that really is going to continue to grow as we move forward as an industry. So just as payer contractual terms have evolved, so will the need for payer scorecards. That's one thing to keep in mind. Begin looking at your current payer scorecards. Start to consider questions like, how are my payers performing in comparison to each other? But also begin thinking about how do they compare with both negotiated charge information, shoppable service information that's going to be out there readily available to the public. So we need to remember that with our scorecards, it's not just where are the additional revenue recovery opportunities, but we need to start to really incorporate into those scorecards that patient underpayment obligation, along with kind of the traditional denial and contractual variances that we've looked at. As consumerism grows, hospitals are going to need to also incorporate and really understand patient trends. So if the patient liability continues to grow, you'll want to know what payers and what services are those negative trends occurring, so that they can be either addressed through potentially gross price changes, your negotiated charge changes, better efforts towards upfront collections, really understanding the price elasticity, and certainly bringing these issues to the table during your upcoming contract negotiation process with your payers themselves. In terms of gross charges, historically, our industry has used gross charge data to look at your retail price as you have done strategic pricing adjustments. Going forward, as we have new data, being the negotiated charge data and the cash price data, we're going to need to incorporate those pieces of information into both our strategic pricing and our payer contract negotiation process. Obviously, price elasticity is going to become something that has historically been more of a limiting factor. The lower the price didn't necessarily drive the need for the occurrence for more services. In other words, if my colonoscopy price was half the current rate, am I going to get twice the amount of volume? Probably not. But we do need to start looking at price elasticity in terms of what's the discount rate from the lens of the payer, if you will, and their ability for price to help drive volume. So it may not be elastic with certain service lines, but it could be more elastic with other things like our high-tech imaging procedures, lab, radiology services. So that's going to be something we need to start to incorporate into the process as we start thinking about consumerism and shopping and analyzing this data a little bit more intently, if you will. So moving forward from there, there really will be a significant amount of data that's got to be considered beyond just the CDM gross charge and the payer contract. And really all this data is going to have to be leveraged in new and different ways. than what we've traditionally worked with. We're just going to have, especially the negotiated charge information, more information to really understand what may help drive volume to us. We're going to need to look at conversion rates. In other words, how much potential revenue am I losing or gaining based upon those shoppable services, and how that shoppable service may actually help convert that patient shopping experience into an actual provided and billed service. So, Brad, I think we're up for our next poll and last poll question.
Yeah, thanks, Greg. And before we jump into our final poll question and start to wrap up here, we did send a live chat to some of the attendees about a free market analysis. So you might have seen that pop up in your message window. If you did see that and you're interested in learning more, go ahead and message us back, and we'll set something up for you over the next couple of weeks. So let's go to our second and final poll question. And this is more of an opinion question of the audience. Do you believe the CMS price transparency mandate will end up helping patients and lowering costs? So let's get some feedback here.
If you do end up using it.
So either yes, you think it's great and we'll do both. Yes, but the patient needs to understand how their insurance works. No, I think this will only confuse patients. No, I don't think, or I think patients won't access the information, or not sure.
Then if you
So let's give everybody about 20 more seconds here to vote, and we'll share the results. All right, looks like most people have voted, so let's go ahead and share those.
Oh, okay. Oh,
Okay, so a little bit across the board here. About half of you think this will only confuse patients. About 30% say yes, but the patient needs to understand their insurance information and how that works. 10% thinks it's great, we'll do both, and then 10% aren't sure. Greg, any thoughts on those results?
No, I think it's, well, yes. I do think it's something that there is a lot of confusion with whether this will really help or not. And I think it is up to us as leaders in the industry to embrace something that we recognize may be confusing. And if we're going to really go beyond just being compliant, we've got to start to think through and really incorporate not just some tactical steps to be compliant, but from a strategic standpoint, how do we really embrace price transparency? How do we move to having a strategy that supports the directive and really helps align with our communities that we service as healthcare providers? Consumers do want to know and understand the cost. This may not be the ideal way of getting there, but it's certainly something that our industry has to embrace. So it's not going to be enough to just meet the mandate by creating the two currently outlined files. We're really going to have to step up. We're going to have to better manage the process going forward. We're going to have to recognize there is new market data that will help us improve our pricing and our negotiating position. So it's going to be, wise to truly understand how we want to evaluate and leverage this new data going forward. Those would be sort of my initial thoughts, Brad, on the poll results. So I think finally, from all sides, CMS, providers, payers, we've consistently stated what patients or the consumer really needs is a true, easy to understand patient estimation platform. I don't know if or when it'll actually be required, but obviously I think that's the direction we're going as an industry, is to truly have online tools that will help consumers understand their costs. And obviously, as you guys work through both the mandated machine readable standard charge file, if you have specific questions, feel free to reach out to me directly or reach out to our organization through Brad. We'd be happy to set up a call to address all of your questions. If we can be a resource in any way, again, just don't hesitate to reach out. Brad?
Thanks, Greg. Yeah, and I think we'll open it up for questions. I know we're probably a little bit over 30 minutes here, but we'll stay on the call here for a few minutes. If anybody does have any final questions, go ahead and enter those in the questions tab in your GoToWebinar panel. And Greg, I have one that came across, and it actually relates to that first poll question as far as kind of how prepared people are. So for those organizations that are maybe a little bit behind the 8 ball, maybe have started but still a little bit behind the 8 ball, what would your recommendation be to them to make sure that they're compliant for 1/1?
Yeah, so what we're finding is the price transparency project, if you will, to pull together the data to build both the shoppable deployment, whether it's a file or an estimation tool, and the time to create the standard charge file, is really about a 4-month project. At this point, we've got about 2 months before January 1st, so it's certainly getting down to the wire. As I mentioned earlier, it's going to be more important to have a plan in place, to have a process in place, to be moving towards being 100% compliant. Obviously, we have clients that we're just starting this process. Just even over the last few weeks, we've had new clients come in that we're starting to work with and kicking off projects. So I would certainly recommend those that are slow getting started or haven't started to definitely get going sooner rather than later. Make sure you've got a documented plan in place, documented steps, so that if you are identified as not being really fully compliant, you've got something to turn back to Medicare and provide them with your plan. If you're unsure about the steps to get there, do reach out to us. We can provide you with some very specific timeline action steps that you do need to get going on to make sure that you are compliant.
Sounds good. Thank you, Greg. And if we don't have any other further questions, we'll go ahead and wrap up here. I'll make a quick plug here for the remainder of our series. This is the first of a 3-part series for revenue cycle success in 2021. Next week, I'll be teaming up with Tara, and we'll be diving into ChargeMaster review strategies for next year and things you need to be considering when you're doing your ChargeMaster pricing reviews. And then the following week, on the 11th, we'll be looking at some actionable analytics that you can use to identify some broader underpayment and denial trends in order to maximize reimbursement, and then use that information to negotiate more favorable payer contracts going forward. So we hope you can join us for those 2 sessions as well. If you do have any other questions about price transparency, please contact Greg or myself. And thank you all for attending, and have a great rest of the week.
Thanks, everyone. Thanks, Brad.